when we say gravidity, okay, regardless of the outcome, this woman has become pregnant, correct? So any pregnancy. So she has 1, 2, 3, 4, and since she is currently pregnant, so 5. She is gravida 5. Now, parity is any pregnancy that has reached 20 weeks onwards, so has reached viability. So 20 weeks onwards. So did abortion reach 20 weeks? Yes or no? Abortion, no. Okay, so that did not count. She had 37 1, 35 2, 39 weeks 3. So she is para 3. Okay, because these are delivered babies. Her current pregnancy, even if it's beyond 20 weeks, it's not yet delivered. So you do not count it as para. Okay? Or you also do not count the abortion as parity because it has not reached 20 weeks. And her current pregnancy, although has reached 20 weeks, has not yet been delivered. So we are settled. Gravida 5, para 3. Now, how many term? TPAL. Term 1, 2. Term. So 2. P, preterm. We have 1. Also 1 abortion. And how many are living? Even though the second pregnancy was born alive, but during his history taking, the baby number 2 or the second pregnancy, the baby died at 3 years old because of dengue. So there are only 2 living. So the answer should be, okay, gravida 5, para 3, 2, 1, 1, 2. Like, what if it's not abortion? What if ectopic pregnancy and then underwent, say, medical management? No surgery, only underwent medical management because a serial beta HCG was done and detected early, so was able to do medical management. Will there be a change of the score? Say, for example, it's not abortion, it's ectopic pregnancy. Will there be a change in the OB score? No change, correct? Because ectopic pregnancy is still considered an abortion, okay? Because that was also raised. What if doc ectopic pregnancy? So there is no change in the OB score, okay? So we will be going through terms, labor patterns, management of normal labor. We'll be touching on abnormal labor, at least the dystocia part, and then the 3rd and 4th stages of labor. So again, physiologic, normal process, but I will be touching on some abnormal process again during labor. So our patient is pregnant, okay, about to deliver. So we will be identifying these 4: life, presentation, and attitude, and position. Okay. Well, we do not consider beyond 20 weeks an abortion. Abortion is less than 20 weeks, less than 500 grams. Let's say missed miscarriage. Her count, she's already 20 weeks. Because, recently I had this case. On her count, she's 21 weeks. But when I did a prenatal checkup with her, the fundic height has not reached the umbilicus. So that's 1, okay? The age of gestation is not consistent with the fundic height. Number 2, I had a difficulty looking for the fetal heart tone. So I asked her to do an ultrasound immediately. On ultrasound, the baby has remained 16 weeks age of gestation with no fetal cardiac activity. So that is a missed miscarriage, and it's considered an abortion because even when, to her count, she's already 20 weeks, but the aging of the baby is less than 20 weeks and the weight of the baby is less than 500 grams. How about twins? Okay, sige. Let's try this again. Okay, erase muna so you won't get confused, ha? It's a good question. Did it come out in your exams? Sige nga. Let's try. Sige. Sabihin natin, the 3rd pregnancy, 35 weeks of gestation, twins. Yan. So, ganun pa din. We will, what you call this? Still count gravidity first and then parity first. Now, is there a change of the gravidity? No. So, the gravidity will not change. So, gravida 5 pa din siya. Diba? Now, the question here, Doctora, will the parity change? There are two babies that went beyond 20 weeks. So, in a multifetal gestation, isang pregnancy lang yan sila. Nangyari that there are two babies in that particular pregnancy. So, the parity will not change. The same pa din, 3. Because there are only 3 pregnancies that have gone beyond 20 weeks age of gestation. Because we're looking at the pregnancy and not yet the outcome. Okay? Pregnancy beyond 20 weeks. So, dito na tayo, the change will be in the parenthesis. Wow. Okay, may nakakuha. Good job. So, ganon, the same for the term. We still have 2 term babies. Twins. Yung isa, ang Ballard score niya, 35. Yung isa, twin B, Ballard score niya, 26 weeks. So, dalawa ng preterm. And then, isang abortion, tapos ilang living. 1, 2. Yan. Good. O, nakuha pala. Okay, you got it. So, ganon. Hindi siya 1. Kasi, there are 2 babies na preterm. But, only 1 pregnancy. Kaya, it did not change the parity. Okay? Okay na, settled na. Tuloy na tayo. Fetal lie. The relationship of the fetal long axis to that of the mother. Every time we identify something of the fetus, the reference point is always the mother. The mother's right or left, the mother's whichever side. Ganun siya. So when we say longitudinal, parallel, okay? When we say transverse, perpendicular naman siya, again, on the long axis of the mother. That's transverse, parallel. Oblique, this is unstable, an unstable line. Fetal presenting part is the portion of the fetal body that is foremost within the birth canal. So, it is part of the fetal body that's closest to the birth canal. Okay, that's the fetal presenting part. So, I tabulated it like this. The part is the head, either the head, the buttocks, the legs, or the feet, or the shoulders. The presentation is, if head is the presenting part, so cephalic presentation. If it's either the buttocks, legs, or the feet, then it's breech presentation. If it's shoulder, that's presenting first, then it's shoulder presentation. And the lie, either longitudinal or transverse. Presenting part. Okay. When you are asked a presenting part, again, do not give me a color. If you are asked for a color, do not give me a presenting part. So presenting part, head. Okay? So not cephalic presentation because the question is presenting part. What is the presenting part? Correct. Next, what's this picture? What's the presenting part? Buttocks. Correct. Ito, what's the presenting part? Oo nga naman. Back nga naman. Pero shoulder siya. Kasi yung back, andun siya pagka-IE mo, it's a shoulder that will, you will feel. Sige. Okay. There are varieties of the cephalic presentation depending on the flexion or the extension of the fetal head. So if it is super flexed, then what you will be able to palpate is the posterior fontanelle, that's the occiput. Sinciput, if partially flexed, partially extended will be the brow. Extended will be the face. Again, varieties of cephalic presentation. Pwedeng cephalic presentation siya, but face naman. Okay? Breech. As you can see in this tabulation, you will be able to appreciate that as the baby approaches to term, the percentage of breech lessens. Doktora, bakit ganon? So, if you recall the pear shape of the uterus, di ba? Pag si baby breech pa, the head is bigger than the body. Okay. Kasi hindi pa siya masyadong bulky. But as the baby grows, nagiging mas mataba ang puwet, the legs become too big, the arms are big. So, it rotates spontaneously. Kaya nagiging cephalic siya. The principle here is that, the more spacious area, dun titira yung more spacious part of the baby. Because during the preterm, mas malaki ang ulo and more spacious in the fundal area. Thus, the head stays there. Kaya it's breech. But, again, correct, as the baby grows, as the baby increases in size, bulkier yung buttocks, arms, and legs. So, the bulkier buttocks will be the one that occupies the fundal area. So, just reassure patients who are preterm with breech presentation that you will just wait because baby will just rotate spontaneously. Wag magpahilot. Okay. There are 3 general configurations of breech. Number 1, frank breech. There is flexion at the hip, but extension in the knee. Okay. Complete breech, both flexion at the hip, flexion at the knee. Okay. In complete breech, pwedeng extended in the hip, extended in the knee, tapos at the other side, flex at the hip, flex at the knee. Okay. How about fetal attitude or posture? Even in the fetal life, we already have attitude, okay? So this is the characteristic posture of the baby. It should be an ovoid mass corresponding to the shape of the uterine cavity. That is the normal fetal attitude or normal fetal posture. However, again, there are varieties of fetal attitude, either convex or it becomes concave, extended. Position. You need to understand position because position will help direct you in the cardinal movements of labor. Now, fetal position, this is where the fetal presenting part is at the right or left side of the maternal birth canal. Again, reference point is the mother. The relationship to the mother's right or left side. Okay, and we look at reference points. Pag cephalic, because the normal attitude should be the occiput. So cephalic occiput, it's the landmark, it's the reference point. For the face, it's the mentum or the chin. For the breech, it's the sacrum. These are the reference points. Wherever these reference points are located to the right or the left side of the mother, that is the fetal position. So I summarize it like this. Fetal position in relation to the maternal right or left. Then there is a reference point, either occiput, mentum, sacrum, or acromion, either directed anteriorly, posteriorly, or direct transverse. So this is how it looks. So there are 3 letters, either ROA, RMP, RMA. You will be combining all these, okay? So for this picture, what is the shape of the posterior fontanelle? Is it the diamond or is it the triangular shape? Okay, so it is a triangular shape. So this will be our reference point. Is the triangular shape at the right or left side of the mother? So the triangle is at the right, correct. So we know that the occiput is at the right. So we have 2 letters already. Is it directed anterior, posterior, or transverse? Okay, so the position of this illustration is right occiput transverse. Although the most frequent or the most common cases of position as the head enters the pelvis is LOT. Okay, 40%. But the next most common is the ROT by 20%. Ayan na, nasagot na kita. Ano, Michelle. Okay? A lot. Para you will not forget. Most common fetal position. A lot. Okay? Next, CROT. Okay? All right. How about this? Because if acromion kasi yung reference point, magiging 4 letters. So, step by step tayo. What's the lie? The lie is transverse. Okay. Presentation. Anong presentation? Hindi back, shoulder. Okay. Shoulder presentation. Reference point, sabi ko kanina, ano nga, acromion. Acromion ba? Yan. Okay. Now, challenge here is the position. You look at again whether right or left side of the mother. So, ito naman, saan ba dito? Right? Itong right ni mommy, di ba? This is right of mommy. This is the left of mommy. So, definitely, the acromion is at the right. So, right, acromion. So, we have 2 letters already. Kaya lang, there is also the factor of the back. Sabi niya kanina, what is the presenting part back? There is the factor of the back. So, we look at the dorsum. Okay. The dorsum is either directed posteriorly or anteriorly. So as you can see with our illustration here, the dorsum is at the posterior part of the mother because it's lying at the back also of the mother. So the position is right acromio dorso-posterior. So with cases like this, there will be a difference in the incision that we use when we deliver. We utilize when we deliver this baby because transverse lie cannot be delivered vaginally. Si face may chance, depending again on the position of the mentum for face delivery. If it is mentum anterior, yes, we can offer a vaginal delivery. But if mentum posterior, kasi nababangga yung ano dito, forehead sa symphysis, so it cannot be delivered vaginally. Again, only mentum anterior can be delivered vaginally, mentum posterior and transverse lie, cesarean section. Now, the next question is, what is the incision? We have, pwede bang, can we do a low segment? So this is not fan and steel. We do not call this incision fan and steel. Kasi si fan and steel is the term we call for the transverse incision in the abdomen. Eh, hindi na ito abdomen. This is already the uterus. So we either call it a classical incision, which is like this, or we do a low segment transverse incision. Okay. Now, basing on these presentations, if it is the back that is occupying at the anterior portion, it will be difficult for us to deliver using a low segment incision. So we will have to do a classical incision for these cases. Okay. Again, classical incision, if it is the back, that's at the anterior portion. But if it's the extremities naman, there's no difficulty grasping the extremities when the back is at the back. Tama? When the fetal back is at the back. So when we do the low segment, nakuha naman agad yung extremities. So we can still do a low segment. Why do I discuss this? Because there's higher morbidity using a classical incision. Remember, a classical incision is done at the fundal area, the most contractile portion of the uterus. So these patients cannot or are discouraged to do a trial of labor after cesarean section because the incision is at the fundal area. Whereas at the lower uterine segment, it's less contractile, so it's more pliable. So there is no contraindication for a trial of labor after cesarean section. Again, classical, low segment transverse cesarean section. Okay. Diagnosis of fetal presentation and position can be done by a Leopold's maneuver, or you can do IE, but the the bag of water has to be ruptured for you to be able to identify the fontanelles. Otherwise, you cannot appreciate with an intact bag of water. Well, auscultation can help you because when you are able to auscultate fetal back, more or less, you know where the occiput is. Because in a vertex presentation, the side of the occiput and the side of the back are the same. The same. Okay. For the sound, we don't do this three anymore. So these are just good to know. So Lupul's maneuver. You have to remember this Lupul's maneuver because you might just be given descriptions. Lupul's maneuver 1, you will grasp the fundus, identify what occupies the fundus. Is it a large nodular mass, which is the breech, or is it a hard round mobile ballotable mass? Say for example, during Lupul's maneuver 1, you are able to appreciate a mobile ballotable mass. So that means ulo niya nandyan. So presentation is breech. Okay? Ow. However, if you are able to palpate a hard, nodular, large mass at fundus, so likely it's the breech. So the presentation is dito, cephalic, as you can see. Lupul's maneuver 2, we palpate the sides, we feel for the hard resistant back and the small irregular mobile extremities. It can either be back is directed anteriorly or transversely or posteriorly, which is why with palpation of the back, Lupul's maneuver, you are able to identify the position because the occiput is of the same direction as to the back of the baby. Lupul's maneuver 3 confirms the presentation and identifies whether the head is engaged or still floating. So we do the Pollock's grip. And Lupul's maneuver 4, we identify the degree of descent and the cephalic prominence. If it is occiput, the cephalic prominence is opposite the occiput. So when we do the Lupul's maneuver 4, the impediment, the prominence is at the other side. Dito yung prominence. Dito na-feel ang prominence in a vertex presentation. However, in a face presentation, the cephalic prominence is of the same side of the back kasi naka-hyperextend. Hindi. Tama. Naka-hyperextend si baby. So, andito yung cephalic prominence, similar to the fetal back. So, if the cephalic prominence is the same side of the fetal back, likely we are dealing with a cephalic presentation but face variety. This is what I said earlier with the ruptured bag of water. You can identify the presenting part, the course of the sagittal suture, whether you are able to identify the position of the anterior posterior fontanelle and identify the station. So, ito, what's her name? DL. Since we started with DL, so we go with DL. So she came in, diba, with regular uterine contraction, gravida, yes, she is a gravida 5 patient who came in for regular uterine contractions. Ito in the rest of her internal exam for CM 60% effaced, station -3, intact bag naman, cephalic, mid-position soft. What's the Bishop score? Sige, let's try. Baka you still remember Bishop score. Sige, good. Ayan. 7, why 7? 2, 4, diretso na ako dito 6, 7. Kasi 2, 2, 2, 1. Correct? Okay. Go. Bishop score 7 siya. So, for us to be able to manage DL appropriately, we must be able to identify the characteristics of a normal labor. So we will be able to decide, should we admit DL or uwi ka muna DL. Okay. So identify what labor is. So of course, it leads to childbirth. It begins at the onset of regular uterine contractions and ends with the delivery of the baby and the expulsion of the placenta. Now the threshold. The threshold for the diagnosis of labor is the presence of regular uterine contraction that brings about demonstrable effacement and dilatation of the cervix. If intact bag of water, it's 3 to 4 cms or more cervical dilatation. So, should we admit? Yes. Kasi multigravit, nasa 4 cm. Tapos, Bishop score niya nasa 7, above 5. So, it's a good score already. That means we can already rely on the uterine strength of the uterine contractions to be able to cause cervical change and effacement. So, stages of labor. First stage of labor, well, there are 2 phases of cervical dilatation, the latent and the active. Tapos there are 3 functional division, preparatory, dilatational, and pelvic. Pero parehos, as you can see, they have similar colors, iba-ibang pangalan. So anyway, again, if you are asked, there are 2 phases only of cervical dilatation, but when as a functional division, tatlo, preparatory, dilatational, and pelvic division. So these are the corresponding phase to the division. Si latent, preparatory division. Si active phase, acceleration phase, phase of maximum slopes, dilatation phase, and deceleration phase. And then, dapat deceleration to pelvic division. Oops. Ano ba? Okay. So, preparatory division, if you sedate the patient, it can arrest the labor, meaning the labor will not progress if you give her sedatives. For example, she comes in pain, and then you give the sedative na wala, o uwi ka na. But, if you are already at the dilatational division, this is where the cervical dilatation proceeds at its most rapid rate, and even when you try to sedate the patient, there is no effect of the sedative. Pelvic division commences with the deceleration phase of cervical dilatation, where the cardinal fetal movements also take place. By the way, where is the deceleration phase, or at what cms do we consider part of the deceleration phase? At how many cms? Sige na. Yan, may nag-chat. Good. Sige pa. Deceleration, ha? I'm asking deceleration. Yan. Yan na. Good. So, may answer dito 7 to 8, 8, 9, 9 to 10. May 6 din. O sige. Saan ba? So, in the book, it says there 7 to 8. However, later in the consensus guidelines, okay, 7 to 8 in the book, I'll be showing the updated threshold for deceleration. So just keep that thought. Sige. Basta you know in the book it says 7 to 8 cms. So we proceed with cardinal movements of labor. I hope you still remember the Ed-Fire ere. E, engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion. Okay. Engagement, it is when the biparietal diameter of the head passes through or enters the pelvic inlet. The act of entering, okay, pag si head naka-enter sa pelvic inlet, the biparietal diameter is already at the pelvic inlet, then that's already engagement. So the question is, okay, how about ito, this, leading edge? Kasi sabi dito, leading edge is at the ischial spine, so nasa station 0 na. So like this, pag si leading edge or tip of the head is already at the ischial spine, okay, the head has already engaged kasi nakapasok na siya sa inlet. It has entered the inlet already, si biparietal diameter, okay? Pero, hindi siya station 0 pa. Because when we measure the stations, it's the biparietal diameter. It's just that it is for us to know that when the head is engaged already, it is at the level of the ischial spine where we consider it to be as station 0. Yan kasi ang landmark of station 0. Okay. So, What is asynclitism? It's the lateral deflection of the sagittal suture. Again, sagittal suture ang titingnan, yung line. Okay, this is the sagittal suture here. This is the sagittal suture. It's the line. Okay. Okay. Hold on, ha. Now, anterior asynclitism, it is when if the sagittal suture is close to the promontory. Anterior asynclitism is when the sacral promontory is, the sagittal suture is close to the sacral promontory. Okay? In comparison to, delete ko muna to, para hindi magulo. Posterior asynclitism, the sagittal suture is close to the symphysis. Medyo baliktad nga eh, but that's really how it was defined by the book. Si anterior, ang sagittal suture is close to the promontory. Si posterior, sagittal suture is close to the symphysis pubis. So these deflections may affect the progress of labor. As long as the deflection is not severe, it should not cause a problem. Okay? Descent. Descent is the first requisite of birth of the newborn. It is affected by 4 forces. Pressure of the amniotic fluid, direct pressure of the fundus upon the breech with contractions, because in this time there is regular, frequent, strong uterine contraction. Okay. Bearing down effort of the maternal abdominal muscle, and extension and straightening of the fetal head. So as you can see, the biparietal diameter has really gone down lower, okay, in comparison to engagement. And as you can see here, what's the common position of the fetal head upon entry to the pelvis? So it's usually left occiput-transverse, right? So as the head engages, okay, it starts because the goal is to internally rotate towards anterior. So from direct left, it's now rotating towards anterior. Ito na, as you can see here, oops, ayan na. It's slowly turning towards anterior, okay? Now, as the head enters, it is the antero-posterior diameter. As the head enters the pelvis, exposes the occipitofrontal diameter, which is 12 or 12.5 cm. But if you recall, what is the shortest antero-posterior diameter nga in our pelvic inlet? Shortest AP diameter. Shortest antero-posterior diameter. Yan. Dapat sure na tayo, ha? Next time. Okay. Todd, through obstetric diagonal. Ito yon. This is how I remember this para mabilis. Sige. All 10. Sige, bahala na kayo mag-isip. Basta obstetric, 10. Diagonal conjugate is 1.5 to 2 cm longer than the obstetric conjugate. Kasi it's the diagonal conjugate that we measure clinically. We cannot measure the obstetric conjugate. Why? Because the obstetric conjugate is from the edge of the promontory to the inner surface of the symphysis pubis. Hindi naman na ginaganon yun sa symphysis pubis. We only do internal exam feed for the promontory and the inferior portion of the symphysis pubis, and that is the diagonal conjugate. Therefore, only the diagonal conjugate is clinically accessible, and so we subtract 1.5 to 2 cm to be able to identify or measure the obstetric conjugate, and it is the shortest distance between. It is the shortest antero-posterior distance. So we go back to flexion. If our shortest antero-posterior distance is 10 cm, can a 12 occipitofrontal diameter enter the 10 cm? Yes or no? No. So the head has to flex for it to enter the shortest AP diameter of 10 cm, and the goal is to flex adequately, exposing the suboccipitobregmatic diameter, so the diameter that enters becomes shorter from 12 to 9.5. So can a 9.5 enter at 10 cm obstetric conjugate? Yes. So that's the reason why the head has to flex for it to enter the obstetric conjugate, the shortest AP diameter of the pelvic inlet. Okay, you get it? Without flexion, it cannot proceed. Yan, it will fold. Okay. Now, internal rotation. Again, sabi ko kanina, the goal is to move anteriorly. Okay. What if, yan, move anteriorly. Posterior fontanelle from that, going there. So, naging direct, ayan, naging direct anterior na siya. That's the posterior fontanelle. Galing sa LOT, it's internally rotating, direct. Oh, naging direct na. Now, what if, doktora, ayaw niya mag-anterior? It remains occiput transverse, or yes, ayaw niyang mag-rotate. So we can help rotation using the Kielland's forceps. Extension. So after internal rotation, mag-e-extend si head. So in this illustration, you will see papalabas na crown na yung head, nag-crown nga yung head, and as the head crowns, nag-extend, the head extends going out, okay? Direct contact in the inferior margin of the symphysis pubis, that's extension. So once the head is out, okay, you don't pull the head right away. You allow the head, because wala pang expulsion, no? After extension, may external rotation pa, may external rotation pa bago expulsion. So you do not pull the baby. After extension, nalabas na yung ulo, you let it externally rotate first. So restitution muna. If the original was LOT, so let the head rotate back to the left occiput transverse position kahit nasa labas na yung head. Now, once it's out, so ayan na, bisacromial diameter na yung nasa antero-posterior area, then we are ready to pull out the head, pull down and up to deliver the shoulders. Okay? Do not hurry. Because after extension, you will pull it out right away. Baka nagkamali ng rotate and turn, nagkamali ka, you force the rotation and it went the other side, you can cause fracture or even nerve injuries. So you be careful. Do not be too aggressive pulling it out. Kaya ni babying hold ng breath ng kaunti. So you let it externally rotate first before you deliver. So those are the cardinal movements. So I said kanina, there are 3 functional labors and there are 2 phases of labor. So active phase, alam na natin si latent phase. So si active phase, now it's redefined to 6 centimeters. So there were answers earlier na 6 cms because it was the active phase, okay? But the deceleration, the start of the descent of the head is at 7 to 8 cms according to the book. Now, you remember this, that Anuli has to progress 1.2 cm per hour and a multi has to progress at least 1.5 cm per hour. Now, kunwari, sino ba tong patient natin? Si DL. Excuse me. Na IE ng alas 12. 6 cm siya. Pag sabihin natin 1.5 cm per hour, dapat at 2 o'clock, 6, 7, 8, excuse me, naging 9 cms na siya. Because that's supposedly the progress of a multi at 2 p.m. Kasi diba, per hour, 1.5. So 1.5 plus 1.5, 3 cm dapat ang na-progress niya. So from 6 to naging 9. Oh my gosh. Okay. So, how do we monitor a patient in the first stage of labor? In the absence of any abnormalities, low risk 30 minutes, high risk 15 minutes. Okay. Ito pala. First stage, low risk, first stage 30 minutes and every 15 minutes a second stage. If high risk at risk, every 15 minutes in the first stage and every 5 minutes during the second stage. Bata. We have cardiotocograms available in our labor rooms, and if there is continuous fetal heart rate monitoring, at least evaluate every 30 minutes for low-risk patients in the first stage, ganun pa din. Tapos every 15 minutes on the second stage. What if membranes rupture? What's the significance? So, number one, there is a risk for umbilical cord prolapse. So, upon rupture, you do internal exam right away because we do not want umbilical cord prolapse or compression. Next is, if there's rupture of membrane, likely spontaneous labor will begin soon. And last, but very important, is the risk for intrauterine infection. Kaya when membranes rupture, whether or not with uterine contractions or not, go to the hospital right away. Now, we used to just have a few ways to diagnose a ruptured bowel. Speculum exam, there is pooling, nitrazine test, diba? The normal vaginal pH is acidic. Now, if it is basic, can be amniotic fluid. Pero pag scanned, you will not be able to maximize this test. I mentioned earlier the arborization, the ferning pattern. Ayan na naman, baka siya gumagala mag-isa. AFP detection, sodium fluorescein solution, and AFP proteins, yung sa, we will be detecting proteins present in the amniotic fluid. If it tests positive, then it confirms the rupture of membranes. So those are the other tests available for us. What to do? Yun na, I said, IE agad to exclude cord prolapse. Check FHT and uterine contractions immediately. Oxytocin administration if contractions are not adequate kasi nag-rupture na. So we want to expedite delivery, oxytocin. Administer antibiotic only during prolonged membrane rupture greater than 18 hours. So in your book, the recommended is still penicillin. It is, although we commonly use ampicillin in practice, but for theory purposes, you should know that the recommended drug is ampicillin as prophylaxis. So how about oral intake during labor? Actually, only solid foods are withheld once active labor because gastric emptying time is prolonged. However, according to the American College of OBGYN Gynecologists, we can allow sips of clear liquids and ice chips and lip moisturizers. How about cesarean section? Now, if elective, the patient is not in labor, we have this early recovery after surgery protocol, the ERAS protocol, where we allow solid food 6 to 8 hours before surgery and allow liquids 2 hours before surgery. So that's the early recovery after surgery protocol. Bladder function. This is very important because a distended bladder can hinder the descent. You might think it's cephalopelvic disproportion, hindi mo lang pala napaihi yung patient. Distended bladder, so hindi siya nag-progress. Okay? What are the presumed benefits? So may cases naman that amniotomy is done kasi there's no spontaneous rupture. Then amniotomy is done. What's the benefit of amniotomy? Amniotomy expedites labor and delivery, so more rapid labor. We can also detect early if the amniotic fluid is stained by meconium, okay? Or although we don't do it, in the book, it says it's an opportunity for us to apply electrode and insert pressure catheter into the uterine cavity. Fetal head, okay, this is the caveat. When we do amniotomy, fetal head must be well applied to the cervix and not be dislodged from the pelvis. Otherwise, pag-aapyo mo at hindi well applied sa cervix, what happens? Cord prolapse. Okay? But after 2 hours of admission ni DL, nako, ganun pa din. 4 cm pa din yung IE niya. What do we do? Should we do CS o magsi-CS na ba? Because hindi siya nag-progress. Doktora, multigravid, tapos may contractions, bakit hindi siya nag-progress? CS na yan, hindi nag-progress. Are we? Yes or no? Raise your hand pag si CS na. Ay, I don't like it talaga do. Lysol. Smells bad. No. Okay. Why? What do you plan to do? Hindi ko siya i-CS, Doc. Sige. What else can we do for this case? Yeah, sabi niya, regular na nga yung contractions niya. Masakit na, Doc. Magpa-admit na ako. Okay. Remember the Bishop score? Bishop score is already 7. Okay na yung 7. Okay. Ay, Bishop score. Okay na Bishop score of 7. So, hindi na tayo mag-ripen. Okay. What do we do? May nagsagot. Amniotomy, augment. Okay. Ayan. Good. So, according to the Labor and Management Protocol, active management of labor comprises of 2. Ito yung amniotomy na sabi ko kanina and augmentation using oxytocin. That's right. So, these are the 2 components. Why? This active management protocol is committed to deliver a pregnant laboring woman to 12 hours or less in labor. That's the goal. Na hindi na natin patatagalin while make the mother suffer and we let her wait for 24, 48 hours. So, if no progress, amniotomy. Pagka amniotomy mo, there is no still progress at the contractions are not adequate o the oxytocin na. Ito yun. This is what the protocol is about. Pelvic exam, perform every hour for the next 3 hours and at 2 hours interval. When dilatation has not increased at least 1 cm per hour, do amniotomy. After 2 hours, if still no progress, you give high-dose oxytocin. So, mauna, letter A, bago O. Amniotomy, then oxytocin. For ruptured membranes before admission, so kumare nag-prom, okay? You give oxytocin if there is no progress at the 1 hour mark. On admission, 4 cm, ruptured bag. After 1 hour, 4 cm pa din. O, oxy ka na. Okay? Again, this is the management protocol from Parkland Hospital. Our goal is to shorten admission to delivery time. And it has not increased cesarean section rates naman. So, we did. Yun na, nag-rupture na. Nag-rupture na si DL. And MBU 250, 6 cm siya 3 hours ago. Pag ai mo ngayon, 6 cm pa din. Naka-rupture na. Adequate naman yung Montevideo kasi 250. Ano na? What do we do? Baka pwede na mag-CS. Kasi CPD na. O, ayan. Saan ba? CS? O, wait muna, Doc. Baka may chance. Saan ba tayo? Nayaman ako sa inyo, ha? Mag-CS tayo. Sige! Okay, let's see. With the Obstetric Consensus Committee. So, sige. You might change your mind after hearing the Consensus Committee. Number 1, prolonged latent phase is not an indication for CS delivery. So, nung for CM, si DL, not indication for CS. So, sabi nyo kanina, mag-intay. Correct. For protraction disorder, protracted yung labor niya kanina. Observe, assess. Adequate ba yung uterine activity niya? If hindi, augment after oxytocin. Okay, so nagawa. Nag-amniotomy tayo. Regular yung contractions niya. So, hindi na tayo nag-oxy. Ngayon, she's already 6 cms. Kaya lang, she has remained 6 cms for the next 3 hours. What's the indication of CS? CS delivery for active phase arrest should be reserved for women at or beyond 6 cms with ruptured membranes who failed to progress despite 4 hours of adequate uterine contraction. So, sa Friedman, 2 hours, diba? 2 hours lang. And nag 3 hours na. Kaya I understand some of you said CS. But in this consensus committee, 4 hours na 6 cms with adequate uterine contractions or 6 hours. If kahit naka-oxy pero hindi pa din, resistant yung uterus niya, ayaw niyang mag-regular uterine contractions. So you wait for 6 hours for those cases. So, for DL, going back, di ba? 6 cm siya for the past 3 hours. What's our decision again? Are we going to do CS or are we going to wait? Based on the consensus committee. Yes. So we are going to wait and survey maternal and fetal status. Okay? So, thankfully, nag 9 cm siya after 1 hour of waiting. Kasi nasa 3-hour mark pa tayo, di ba? So we have 1 more hour to wait. Naging 9 cm, 90% station, -2 ruptured cephalic. Okay. Then, after 30 minutes, wala na, bilis na. Fully dilated, fully effaced, station -1, ruptured cephalic. And, yay, delivered. Nasa second stage of labor na tayo. So, it begins complete cervical dilatation and ends with fetal delivery. May problem pa din because this can be highly variable and median duration depends. 50 minutes for newly, 20 minutes for multi. And there can also be prolonged second stage. Dito, according to Friedman, 3 hours for newly, 2 hours for multi. Again, I will give you a summary later. What are the changes that we are embracing, okay, to decrease maternal and fetal morbidity and mortality? So, we prepare kasi 10 cm na siya. So, dorsal lithotomy is the most common and most satisfactory position. Just be mindful that if you let the mother sit prolong or squat for a long time, there can be a neuropathy of the common fibular or peroneal nerve. It's the same nerve. It's just different names, fibular or peroneal, but referring to the same nerve. Again, prolonged sitting, ha? And then, we are thinking mag-episiotomy ba o hindi. Remember, your patient is a multigravid. Baka hindi kailangang episiotomy. So when we do episiotomy, it should be restrictive. Ano bang restrictive? We choose our patient, sino? Pag multigravid at open na open, so why still do episiotomy? You just have to let the head descend and extend slowly through a modified Richards maneuver to avoid lacerations. Dapat controlled head delivery para lacerations are avoided. But if you think that an episiotomy, again, based on clinical judgment, not because it is routine, you should assess, do I need to do an episiotomy or I may not do an episiotomy? So, ang tawag dyan, restrictive. You choose. There is midline and mediolateral. Okay si midline because it's easy to repair, very rare faulty healing, minimal ang pain, excellent anatomical result, a lesser blood loss, rare dyspareunia, kaya lang extensions are common. San bang extensions? Usually at the external, internal, anal sphincter, and rectum kasi midline, diretso siya. Whereas, sorry, mediolateral, although mahirap, extensions are uncommon. So if you see that the perineal body is short, okay, wag nang mag-midline kasi diretso yan sa anal canal. So you choose mediolateral. So again, I mentioned modified Richgens. So a summary is, again, 6 cms, beginning of true active phase, CS delivery only for active phase arrest, 6 cms with adequate uterine contractions for 4 hours, 6 hours pag inadequate. 3 to 5 cm cervical dilatation, early active phase, not an indication for CS delivery arrest disorder. Manage as protraction disorder. So expectant, rest, augment. Friedman's criteria for CS still holds. May ano naman, Friedman's criteria. Still, same 14-20, but then again, unless we have indication to expedite, but if wala naman, we allow the woman to really go into labor kahit na, even when she is at her prolonged latent phase. Prolonged deceleration phase, ito yung sabi ko kanina. Previously, 7 to 8, tapos may update ang consensus guidelines to 8 to 9. Now, very recent, 9 cms na. Meaning, you can only diagnose a prolonged deceleration phase pag nasa 9 cms. Therefore, 6 to 8 cms, active phase arrest, yan sila. If there is no progress in 4 hours. But if it has reached 9 cms and it has not, the head did not undergo the deceleration phase yet, then we can diagnose and do CS for prolonged deceleration phase. Newly, 3 hours, multi 1 hour. Prolonged second stage, diba kanina you saw the 3-2? For prolonged second stage, same. 1 hour for multi, but 2 hours for newly. Mabilis ma-remember. Second stage, 2 hours for newly. So, kasi parehos lang naman, prolonged deceleration tsaka second stage for multi, same 1 hour. But for newly, there's a difference between deceleration and prolonged second stage. It's nasa second stage na 2 hours waiting. Okay, kunwari, sige, na-deliver natin. What's next? Deliver na the placenta. Pwede tayong expectant management or we can manually remove the placenta. Okay, if there is brisk bleeding. We have to wait for signs of placental separation. Why? Because this can happen. If the uterus is not contracted, this you pulled so strong, you pulled out the placenta. You can cause uterine, ano ba? Inversion. Si uterine prolapse, yun yung kanina, yung mga Delancey level of support, level 1, cardinal ligament, level 2, levator ani, level 3, yung perineal membrane. Yun si uterine prolapse, yon pelvic organ prolapse. But if you pull out the placenta na hindi contracted ang uterus, you will cause uterine inversion and it's an obstetric emergency. So ano nga ba mga signs of placental separation? 1, the uterus becomes globular and firm. There is often sudden gush of blood. Uterus rises in the abdomen and the umbilical cord protrudes farther. There is lengthening of the umbilical cord. Kung kanina may active management of labor, we also have active management of the third stage of labor or the AMTL. The better term for the cord clamping is timely cord clamping, controlled cord traction to deliver the placenta, and then administration of oxytocin while delivering the placenta. Hindi yung deliver the placenta saka ka mag-infuse ng oxy. No, you give oxytocin while you are trying to deliver the placenta. This will limit the postpartum hemorrhage. Oh, may fourth stage pa. Fourth stage, this is when the hour immediately following delivery. Although oxytocins are administered, postpartum hemorrhage as the result of uterine atony is more likely at this time. That's why it's a critical time. Kaya nasali si fourth stage of labor. Okay. Apart from tonus, there are other causes of postpartum hemorrhage. These are tissue, natira si placenta, hindi nalabas lahat. Thrombin, there is a bleeding disorder. Or trauma, may laceration, hindi mo pala nakita. That's why she bled. Okay? So the lacerations, there are different types. We're almost done. Kapit lang kayo. Down to the last few slides. I promise, I end before 5. Sorry, mahaba kasi. Okay. First degree, it's the skin, the fauciae. It has, just remember, it has not involved the fascia or the muscle. Basta walang fascia, walang sabing fascia or muscle, first degree. Pag may kasama ng fascia and muscle, second degree. Basta wala pang kasamang sphincter, second degree pa tayo. What muscles are involved? Bulbocavernosus and superficial transverse perineal muscles. Hindi perineal membrane, ha? Perineal muscle po yan. Third degree, ito yon. Ito yung si sphincter. There are degrees. May A, B, C. If less than 50% of the external anal sphincter is involved, A lang. If more than 50% but excluding the internal anal sphincter, B pa yon. Pagkasama na full through and through plus internal anal sphincter, that's 3C. Okay? It will be called a 4th-degree laceration kapag nag-throughan. Pag ganun mo, diretso ka na sa canal. So, may rectal mucosa exposure. Now, why is it important that we identify the degree? Bakit pa kayo nabibigyan ng extension pag nag 4th-degree laceration or 3rd-degree laceration? It's because this anal sphincter complex has several functions, including continence. The external anal sphincter provides squeeze pressure, anong tawag dito? Voluntary squeeze pressure, although it also contributes 25% of the resting pressure. The internal anal sphincter contributes majority of the resting pressure, meaning pag DRE mo, dapat hindi siya lax, dapat may konting tone. There should be a tone brought about by the internal anal sphincter. Because nga, internal anal sphincter is in charge of fecal continence at rest. Natutulog ka, syempre, you will not be able to soil your underwear. Because your internal anal sphincter is working properly. However, pag anong tawag dito, pag you injure, kumari, nag-assist ka ng delivery, nagpanik ka, hindi mo na-support, hindi ka naka-modified regions ng maayos, nag-lacerate siya, okay? Ganun ang head, nag-lacerate dire-diretso hanggang rectal mucosa. What happens? Even though how good your surgeon is, kan gaano kagaling si OB mo in repairing, it can never return to its usual or pre-injury state. The function will not return to its pre-injury status. The injury remains. And unfortunately, pag ganon, there will be incontinence. Nauutot na kahit saan, hindi ka na mapagpigil. Nauutot ako, ganon agad. Pag kasama si internal anal sphincter, there will be fecal soiling, incontinence of liquid, stool, and flatus. So, I had this patient, she delivered in lying in. She came because the perineal body is very thin, parang it's paper thin. And her complaint was only that, kasi doc, manipis, papaayos ko lang. When I tried to extract history, she does not go to malls anymore because she's afraid pag natatais siya, she will soil the underwear because she cannot hold. Kahit stool and flatus, she cannot hold it, unfortunately, because of this injury. Kaya it's very crucial that you do your role in doing the modified Tritt-Jeans maneuver to avoid high-order laceration. Pag high-order laceration, magkaka-oasis or obstetric anal sphincter injuries. So will we help decrease morbidity among our patients who delivered by making sure that we will not reach 3rd or 4th-degree laceration. So, kunwari, magaling ang support at 2nd-degree laceration lang. So this will be our final diagnosis. Kasi nakapanak na siya. So from P3, naging P4, naging 3 ang full term, 3 living. Okay? So status post, repair of 2nd-degree laceration.